Kaiser Permanente's Community Health Initiative is an obesity prevention initiative aimed at creating opportunities for safe physical activity and healthy eating across the nation, similar to many initiatives that have begun since we started 10 years ago. We were one of the first out of the gate, together with the California Endowment, and the entire time we've had a rigorous evaluation in place. And we've taken that evaluation very seriously, really taking an honest look at what's worked and what hasn't worked, and making course corrections along the way, trying to be brutally honest with ourselves and using the evaluation to improve our investments. I'm going to focus today on the lessons learned that we've had over the past 10 years, with a particular emphasis on the challenges we've had with measurement. So we started 10 years ago with 3 sites in Colorado, and over the past decade we've grown to over 50 sites, with the majority of them being still in Colorado and also in California, where Deborah's site, and she mentioned a lot of the details, hers is called a HEAL Zone. We call our overarching initiative the Community Health Initiative, but each region calls it something different in the name of acronyms. To date, we've invested over $45 million across all of these sites. And we've seen pictures like this throughout the day. These are the community transformations that we're starting to see across the nation. There's now more access to safe physical activity and healthy eating, and the communities are transforming, like what you see in these pictures. But what we've realized over the past 5 years or so is that we really need to focus on the nature of those changes. Is behavior changing as a result of those changes? Is health improving? And that's what I'm going to talk about today. This is our logic model. Can't have a measurement discussion without a logic model. At the end of the day, we're interested in improved population health. So that's on the right-hand side of the logic model. But we spend a lot of our evaluation resources in the middle. And we have evaluation measures and methods throughout all the boxes and circles here, but the majority are focused on the intermediate outcomes. We're interested in understanding the community changes and how those changes are impacting behavior and eventually health. We also take a look at community capacity, and we really take seriously evaluation as a learning strategy. So about 5 years ago, in the name of learning, we took a look at our work. At the time, we had only 8 communities, but we didn't have any population health data yet because we were still early on in the initiative, but we took a look at how likely are we to get to the end game of population health improvement if we stay the course. We pulled out our evaluation data, rolled up our sleeves, and took a look, and we came to the conclusion that it was quite unlikely that we were going to reach population health improvement in health behaviors at the population level if we did not make some course corrections. And so these are our 2 key learnings in that process. The first is that we didn't have strong enough interventions. And because of that, we created this concept of dose, which I'm going to explain in a second, but it's this idea that if you want to move population health, you need to have strong interventions to do that. And the second learning was that we needed to focus more on intermediate outcomes. And so what this meant was that we needed to look more closely at the changes that were happening on the ground and how they were impacting people's behavior and health. And so these are the circles in the middle side of that logic model. We needed to find a way to quantify them and link them to population health improvement. So this is dose. In a nutshell, what it means is how many lives are you touching and how strong is that touch? Is it strong enough to move behavior at the population level? And when we talk about this with ourselves, with other funders, other practitioners, researchers, and our community partners, it resonates with people. The problem has been operationalizing it, and Deborah can speak to that a little bit how this worked on the ground in the Q&A if folks have interest. But it's resonated, people understand it, and then you have to work with community. You can't have dose if you don't have community ownership of it. So the operationalizing of how to create dose, and then we've been building out more recently how to measure it. It's probably our biggest contribution to the field, this idea that I already mentioned: if we don't have dose, we're unlikely to see impact at the population level, Or the other way of saying that is if you have a strong enough intervention, you can move population health, and I'm going to show some of that in a second. But there's been three roles to our evaluation effort in creating and measuring dose. The first has been the role of the evaluator in the planning phase and the implementation phase of working with communities to really build out strong interventions, to really accelerate the work to get to the outcomes that we're all trying to achieve, which is a healthier community. And then there is an approach to quantifying it. So how do you add up apples and oranges of different strategies to get to a common metric? And then how do you use that metric to estimate population health improvement while you're waiting to be able to measure it? And how do you engage community in all of those things? You can't move dose if you don't have community engaged, and you can't measure it either if you don't understand the work on the ground from the eyes of the community, really looking under the rug. Okay, so this is how we start to have those conversations with ourselves and with community about how to build dose. Take healthy eating. We start where people are. So let's say we have a community that wants to work on healthy vending machines. So we talk about, okay, how about putting 50% healthy options? How about 100% healthy options? If you can't do that, how about removing the vending machines altogether so we get rid of the unhealthy options? Then in a school, how about taking on the cafeteria, a la carte food, competitive food, what's sold at sporting events, celebrations, really taking a look across the entire campus and creating opportunities for healthy food, saturating the campus, touching the kids and their staff and teachers throughout the day, every day. The idea is to surround people with health, and once we've taken on the campus, then move into the other sectors. So in this example, and this is just an example of how to build dose, in this example, then we move from the school to what's going on outside the school. What are kids passing on the way to and from schools? How about those corner stores? How about the mobile vendors that are hanging out right outside the schools? And really taking a look at how do we reach the community and the other sectors with this dose strategy. And with an example of physical activity, we have a lot of places that want to start with a walk to school event. I believe Safe Routes to School Day is right around the corner. So we start with that, where the community is, and then we talk about, okay, how about a walking school bus? How about more days? How about more kids? How about to and from school, district-wide? Really having conversations about how do you build the reach, and how do you build the strength so it's happening as much as possible, really as much as possible, so not forcing things that aren't possible, but really this is about having conversations to build the strength of your intervention. So once we've got walking, or even before, we talk about, okay, what can we do to make it safer for people to walk to school? How about some crosswalks? How about some sidewalks? What makes sense to really facilitate folks' ability to walk to school? And to engage the parents on the walking too, really reach out into the community. And then look inside the school. So perhaps we can revamp the PE curriculum or put recess in classrooms, or what are the other ways? And this doesn't necessarily go in this order. We've found in California that sometimes it's been easier to build sidewalks than make changes in schools over the year, in PE over the year. But it's really dependent on the community. And just to hit the point, it's about starting where the community is and continually ask the question, can we reach more people, more times, more often, for a longer period throughout the year, and doing it in any sector? And then we needed to improve our measurement. So we really needed to take a look at how we could better measure the work that was going on the ground. So how we could look in these environments, places like this. So these are the places where we've done evaluation efforts, really looking at how do you get from the community change to behavior change? Are we getting there? And so really taking a look at individual strategies and measuring them so we can quantify the impact, and working with community to understand what are the places where we have opportunities? Where should we invest evaluation resources towards really being able to better tell the story? And we did this strategy in response to two things. The first was the challenges we had with population health measurement. And the second was at the request of the community, who said, you need to measure more of what we're doing, more of the work that we're doing on the ground. And so this was our response, was to really make a play in the intermediate outcomes to take a look at what was going on, the impact of those changes. And here is a flavor of some of those results. This is a Safe Routes to School effort, and this is a combination, this is 13 schools in a community, and it's a combination of safety enhancements, infrastructure changes, programs, promotions, different in every school. But when we did our evaluation efforts, we were able to see more kids were walking to school, and we measured it 2 years later. after we made the changes, and so we were also able to say, it looks like it's going to stick. And this is another example. We've got cafeteria conversions all over the country in schools and also in work sites. And so this is actually an example in Colorado that looks at where they added a salad bar to an elementary school. And when they measured kids' consumption, they were able to see that kids increased their consumption of fruits and vegetables by 13% after the installation of this salad bar. And these are just two examples. So now that we had an inkling that dose mattered, and we were beginning to build the evidence of what it meant, we knew that we had to take it up a notch, because this is a multi-sectoral initiative with multiple strategies going on at the same time, so we needed a way to quantify the collective impact of what was going on in that community. So this is just one example. We needed, with multiple strategies, we needed a single metrics. We needed a way to add up apples and oranges. And in order to do that, we needed a yardstick. And dose was our yardstick. It was our common metric. We were able to look at the different strategies that this community, this is a community in Livewell, Colorado, and they're doing a combination of policy, environmental, and programmatic efforts. They're revising their PE curriculum, they've got some health ed going on, Safe Routes to School, they've got some promotion, and then they're doing some work in after school. And so how do you look at the effect sizes of each of those strategies? And we did this through a combination of three things. First, we did it by looking at the literature to see what effect sizes we could get from the literature alone. And then we did, where we couldn't get effect sizes, we did individual evaluation efforts like what I showed you in the past two slides. And then where neither of those existed, because the literature is still sparse in some areas or it doesn't translate into the environments where we're working, then we did what's called a dose estimate. So we had certain criteria, and using the combination of reach and strength, we were able to come up with a dose estimate that is some of these effect sizes are from the literature, some is from actual evaluations, and some is from our own dose calculations. And for this, we were able to add up the apples and oranges, and in this case, we got it 9%, which actually is very, very high. So what this would tell you, your estimation of 9% would tell you that we would predict that this community would see population health improvement based on the estimates that we made looking at all the individual strategies and adding them up. And the key here is to do this first, to do the dose estimates first, and then look at the population health. So in a nutshell, here we're trying to understand, if you want to understand your community impact, you need to take a look at both the intermediate outcomes and the population health. So here's how we do that. The first is the estimated impact. This is from the previous slide. This is the 9%, where you take the single outcome of physical activity and the single metric, adding all those strategies up together, you get 9%. It looks like this. Then we conducted surveys, pre and post, looking at kids in this particular school, and here we saw a 4% increase in kids reporting more minutes of physical activity. And this was significant, which is also rare in small samples of elementary school kids. So what you're looking for here is an association. And then we compared it to secular change just to make sure that we could stand behind what we were saying. And the secular change at that time in Colorado, using the youth risk behavior surveillance system was flat, basically, over the same time period. So what did this tell us? This supported our hypothesis that if you have a strong intervention, you can move population health, and it reinvigorated our belief that we need to create dose and we need to measure it. So because what I just explained I know is complicated, and also this is a very new strategy for us, so just making sure we're all clear on the steps. The first thing you do is you take a group of strategies, we call them dose clusters, so a group of strategies looking at a single outcome, and you quantify them using a combination of literature, evaluation efforts, and dose estimates. Then we take surveys that we conduct, depending on the strategy, either with youth or adults, looking at behavior change, and compare those to benchmarks. And what we're doing is we're looking for associations between the estimated and measured impact. And if we see those, we feel more confident that the changes that we're seeing in population health can be attributed to the work that we're doing on the ground, to the intervention. This is all complicated, so bear with me. because of where we are, we only have a handful of communities that have population health data so far, just because of where we are in the initiative. But over the next 2 years, this is what we're hoping to do, to create some kind of graph like this that looks at the associations. So we'd have population dose on the bottom, or dose on the bottom, and population level change, so the measured change, the estimated change on the bottom, and the measured change on the left. And if the two line up, then we can feel more confident that we're clear on our outcomes, that what we're demonstrating in the measured outcomes can be attributed to the intervention. So what does this all mean? In a nutshell, I would say that the evaluation, our evaluation suggests that you need to focus both on population health measurement and also on measuring intermediate outcomes. And they're both important for different reasons. They're both hard. We've grappled with a lot of people in the room on exactly how to do this, and we're still working it out. This is all new, especially the estimating and predicting that I just explained is a new strategy over the past year. So we're looking to build that out. But the population health measurement is critical, even though it takes a long time. I think that's already been, it takes a long time to create it. Takes a long time to measure it, and sometimes you can't measure it, even when you have a strong intervention due to power or other problems with the data. But even small changes are very meaningful. If you can detect small changes, it's over a population, so it's a really big deal. For intermediate outcomes, they're important for understanding the work on the ground, for really taking a look under the rug and saying, is something changing and what does it mean? How is that impacting behavior? And really understanding that the work you're doing is leading towards that population health change. And then while you're doing both of those, you also need to be able, the evaluation needs to provide immediate feedback for program improvement. We need to make sure that we're able to tell our communities that they're on track, and in ourselves, that we're on track, and that we're providing evaluation information for program improvement to build out the strategies and make things even more impactful. We also need to continue to build the evidence on all of this. On the concept of dose in particular, it's creating quite a buzz in the field. It's pretty clear so far that creating dose is important. The measurement part is pretty brand new, and so we need to work on testing that and to understand if this really is something that matters and that can lead, that we can stand behind. So far it's looking like that, but we're early on in our learnings here. And also, like the field, and some folks in this room, we've learned that school is a ripe area for creating strong interventions and for measuring them. You can survey the kids and pick up on population health improvement. We showed one example of that, but we're seeing that across the nation, as are others in the field, and that also aligns with some of the recommendations by the Institute of Medicine. The community is much harder. It's harder to document, it's harder to reach the population in a community, and it's harder to saturate it with aligned efforts. But we still think that the dose effort, the dose methods is important in both creating strong community interventions that work with multiple sectors and in measuring them. And at the end of the day, this can help us decide which interventions are more promising. It can help us prioritize interventions or collections of interventions, and still more work needs to be done to build the field on what works and what doesn't. And we think this is one important piece of learning how to inform the field.